Hello, my dear friends. I am Dr. Darshan Dave, and in the series of the pharmacodynamics, this is the fourth lecture on the dose-response relationship. In the previous classes, we have discussed about what is pharmacodynamics, principles of the drug action, different types of drug action, and in these in detail about the receptor-mediated drug action. Now today we will see a very important topic, that is dose response relationship. But before going ahead, please subscribe this channel Pharmacology in Simplified Way, and if you find this class is helpful, then you can share among your colleagues also. Okay, then learning objectives of the today's lecture are: what is dose response relationship, what is the need of dose response curve and log dose response curve, concept of efficacy and potency. These two terms will repeatedly come in your future pharmacology lectures. So it is very important to understand these two terms. Then therapeutic index and therapeutic window phenomena and drug selectivity. So we will go one by one. First of all, what is drug response relationship or dose response relationship? Now, whenever we are giving any particular amount of the drug to a patient, that certain amount of the drug is going to be absorbed, then that drug is distributed, some amount of the drug before reaching to the target site also metabolized, and the drug reaches to the target site. Even though we are measuring dose plasma concentration relationship, but the more important is the dose target site relationship. But as you have seen in the pharmacokinetics that we cannot measure the concentration of the drug at the target site, and that's why we assume that the concentration achieved at the target site is more or less similar to that of plasma concentration, and that's why there is a dose plasma concentration relationship. So what do you mean by dose plasma concentration relationship? The amount of the drug that you are going to administer, out of this certain amount of the drug is remain in the plasma which is available for the action, and this is included in pharmacokinetics. The pharmacokinetic principles will decide the percentage of the drug reaches to the plasma after administered. Now what the next? Once the drug reaches to the plasma, then the drug reaches to the target site, and after reaching the target site, that particular amount of the drug, it produces a response. So the correlationship between the drug administered and the effect produced, that is called plasma concentration effect relationship, and that is decided by the pharmacodynamic principles. So in short, when there is a dose response relationship, first there is a dose plasma concentration relationship and then plasma concentration effect relationship. That is known as a dose response relationship. It means that some amount of the drugs that you are giving, it produces a certain amount of the response, and the relationship between the dose and the response is known as a dose response relationship. And these can be discussed with the help of the graph that is called the dose response relationship. On the x-axis if we put the dose, and on the y-axis if we put the response, then you can see the effect is more or less similar to like this. It is the shape of rectangular hyperbola. It means that first you see, whenever you are increasing the dose, the response is also going to be increased. But after some time, the rate of the rise in the response is not proportionate to the dose. And again after some time, the response reaches a peak It means that even if you further increase in the dose, there is a no further increase in the response. And that is known as a dose response curve. It is a typical of rectangular hyperbola. And when you convert this dose into log dose, then the shape changes. It achieves the shape of sigmoid or S-shaped curve. Okay. Now, what it denotes? Again, the points of the dose response curve will remain over here also. That initially whenever you are increasing the dose, there is an increase in the response, and after some time, even if you increase the dose, the rate of the rise in the response is not that much as that of the previous dose, and finally it reaches a peak. But here there is another difference, that if you can see the middle portion, that is between 30 to 70%, there is a linear relationship between a dose and a response. Okay, this is the one thing, and this is helpful for the comparison of the drugs. And what is the other advantage of the log dose response curve? You have learned in the mathematics, when you convert the dose into the log dose and then you plot on the graph, then you can cover the wide variety of the dosages. That is one. Second, comparison between the agonist. It can also be possible, and later on we will see. We can study the antagonist, the nature of the antagonist, all this with the help of log dose response curve. So these are the uses of dose response curve and log dose response curve. Now, the two important terminologies as we have discussed in the learning objective, that is efficacy and potency. Now this is a drug A. Okay, again I am just revising in one or two slides, that on the x-axis there is a dose, on the y-axis there is a percentage of the response, and on the top you can see the 100% response. And this is the log dose response curve of drug A. Now here you can see in the dotted line, this is maximum achievable therapeutic effect. It means that beyond this, even if you are increasing the dose, the response is not going to increase. So this is known as a maxima. Okay, and this is defined as a efficacy. So efficacy means maximum achievable therapeutic effect with the drug. Now you choose another dose, say for example the dose with which the 50% of the response is produced. So for 50% of the response, the required dose is this much. Okay, and that is known as a potency of the drug. So what is potency? Potency is the amount of the drug required to produce certain response. But if you just think that if I am speaking that this drug is more potent, whether it gives any clear image or understanding, your answer will be no. But I will say that this drug is more potent than this, then it is somewhat more useful. Okay, then we will see this with an example. Now suppose this is a dose response curve of drug B. Now for producing the same response, the 50% of the response, the amount of the drug required B is this. It means that for producing the same response, the requirement of the amount of drug B is more as compared to the drug A. So we can say that the drug A is more potent as compared to drug B. And this is the concept of relative potency. It is clinically very important. So efficacy. Efficacy is the parameter. It is used for the selection of the drug. while the potency is the parameter. It is used for the selection of the amount of the drug to be given, or we can say the selection of the dosage of the drug. Is it clear? Now the next is, here you can see the dose response curve of drug A, then drug B, then drug C, then drug D. Now the question is, you have to compare the efficacy and potency of given drugs, drug A, B, C and D. How will you compare? So first there is a comparison of the efficacy. What is efficacy? Maximum achievable therapeutic response. So here you can see the maximum achievable therapeutic response of drug B and drug C is similar. So we can say that drug B and C are equally efficacious. At the same time, efficacy or the maximum achievable therapeutic response of drug A and D are similar. So drug A and D are equally efficacious. So by comparing the maxima, you can compare the efficacy of the two drugs. Now for the potency, we define a particular response, that for producing this response, the required amount of the drug A is this, drug B is this, drug C is this, and drug D is this. So you can see that the response is fixed. For producing a certain response, the amount of the requirement of drug A is least. The drug B is more than drug A. The drug C is even more than drug B. And the drug D is even more than drug C. So we can say that drug A is the most potent, because for producing a certain response, the amount required of drug A is least, while the drug D is the least potent. It means for producing a certain response, the amount required of the drug D is maximum. Okay. So just by looking at the graph, you just observe carefully that as we are going on the right side, if there is a rightward shift, it means the potency is decreases. So more the amount is required to produce a certain response. So rightward shift means the drug is less potent, and the left shift, the drug is more potent. It means the less amount of the drug is required to produce the response. So from the dose response curve, we can get the information about the efficacy of the drug. We can compare the efficacy also. We can compare the potency also. All these parameters can be measured. Now the next is, again on the x-axis there is a dose, y-axis there is a percentage of the response, and this is the dose response curve of drug A. And my dear friends, this is a dose response curve of drug A for bronchodilation. Again, you have learned that a particular drug, if it produces only one beneficial therapeutic effect, then it is the best. But it is not possible. Drug produces various actions. Okay, so there can be different dose response curve. If the drug A produces, say for example, effect X, then there is a dose response curve for that effect. If the drug produces some another effect, then there can be a dose response curve of that effect, and these are different. Okay, so here the drug A, it is an anti-asthmatic drug. So obviously we require a beneficial effect, that is bronchodilation, and this is the dose response curve for bronchodilation of drug A. Now this is the same dose response curve of drug A, but it is for the cardiac stimulation. Okay, so now obviously if the patient is having asthma and if a drug is producing the cardiac stimulation, increases the work of the heart, obviously we don't desire it. so it is an adverse effect. So the another dose response curve is produced for the adverse effect. So what I want to convey is for a particular drug, the dose response curve for therapeutic effect and adverse effect is different. Now can you interpret this graph? That what is the difference between the dose response curve of therapeutic effect and adverse effect? The difference is that the amount of the drug A required to produce the therapeutic effect is significantly less as compared to the amount of the drug A required to produce the adverse effect, that is cardiac stimulation. So the drug is relatively safe in a lower dose range. Okay. Now the drug B, same antiasthmatic drug, it produces the bronchodilation. This is the dose response curve for bronchodilation, and this is the dose response curve for cardiac stimulation. Here you can see that both this dose response curve, they goes hand in hand, very close proximity. It means that with the same dose you will get the bronchodilation and you will get the cardiac stimulation. So the therapeutic effect is observed only and only if you can accept the adverse effect. Okay. Now my dear friends, can you just identify the drug A and drug B? Okay. Now I will give you the answer of this, that we require a selective bronchodilation. You all know that the beta 2 receptors that are present on the bronchial smooth muscle, and when these receptors are stimulated, there is a bronchodilation. And the beta 1 receptors are produced on the heart, and it causes the increased cardiac contraction and in general cardiac stimulation. So the drug A is selective beta 2 agonist in nature. So it selectively stimulates the beta 2 receptor and produces the bronchodilation, and in very high dose it can stimulate the beta 1 and causes cardiac stimulation. So the probable nature of the drug A is selective beta 2 agonist, and that is salbutamol. Now in the drug B, it stimulates both beta 1 and beta 2 receptor. So it is a non-selective beta agonist, and that is isoprenaline. Now what is its clinical importance? The importance is that we can use salbutamol for the treatment of the asthma, but we cannot use isoprenaline for the treatment of asthma. Now the next point is, here you can see a hydrochlorothiazide. It is an antihypertensive drug. It is a thiazide diuretic. The dose response curve of hydrochlorothiazide and the dose response curve of hydralazine. It is again another antihypertensive drug. Please don't bother or take tension if you cannot remember of the name of the drug right now, but I want to tell you about the type of the curve and its clinical importance. So the curve of the hydrochlorothiazide, you can see that it is a flat. It is a flat dose response curve. And what is the interpretation of this flat nature? That even if you are increasing the dose, the percentage of the increase in the response is not much more. Okay. So even if you increase the dose from 50 milligram to 100 milligram, say for example, even if you double the dose, there will not be significant rise in the response. Fine. So you should not worry much about what will happen if I increase the dose more in case of flat dose response curve. While the curve of hydralazine is steep dose response curve. Here you can see in the initial part, even the slight increase in the dose, there is a drastic increase in the response. So one must be very careful while increasing the dose of such kind of drug, because even if there is a minor rise in the dose of the drug, there is a disproportionate increase in the response. Okay, so from the type of the curve you can get this information about the dose titration. Then next, these we have seen that this is a therapeutic effect of a particular drug, say for example drug A, and this is the adverse effect of the same drug. Okay, you can compare with the example of the previous one, the bronchodilation and cardiac stimulation. Now initially we have seen in the first or second slide that normally when you increase the dose of the drug, there is an increase in the proportionate response. So in the therapeutic effect also, if you increase the dose, there is some therapeutic response. Still, if you increase the dose, somewhat more therapeutic response. And clinically, we require, there is a variation from patient to patient, but in a particular patient, we required a particular therapeutic effect. Okay, at least we want this much therapeutic effect. So this percentage of the response or this percentage of the therapeutic effect we must want. So this is known as a minimum required therapeutic effect. And the same way for the adverse effect, again it is obvious that for a safer drug the adverse effect starts producing with a higher dose. Okay, but if you again increasing the dose, there is a more severity or the frequency of the adverse effect, but a time comes or at a particular dose that you can tolerate this maximum adverse effect. Beyond this you cannot tolerate, or you cannot go beyond further increasing the dose, and that again it varies from patient to patient, condition to condition, but there is a defined amount that beyond which you cannot go, and that is known as a maximum tolerated adverse effect. So there is a dose at which a minimum required therapeutic effect, you cannot prescribe an amount of the drug less than that, and there is one upper range beyond which you cannot increase the dose because the adverse effects are not tolerable. Okay, and we have to prescribe the drug in between these two ranges, and this is known as a therapeutic range, or we can say that the therapeutic index. Now a last but very important parameter, that is drug specificity. Now as we have discussed, a drug can act on specific target, or drug can having a non-selective action. If the drug is having a specific target, and then there are chances of producing specific action, and the classical example is omeprazole. Omeprazole is a proton pump inhibitor which is present on the gastric parietal cell, and it specifically acts on this pump, H+1, K+1 ATPase pump, and that's why it is having specific acid suppressant action, no other action. Okay, while the another possibility is that the drug is acting on the specific receptor, then your answer will be same. If the drug is acting on the specific receptor, then it produces always specific action. But my dear friends, it is not true. And the correct answer is it may be producing the specific action, and it can also produce a wider non-specific action also. And I will explain you with the help of the example corticosteroids. Now corticosteroids are acting only on the specific corticosteroids receptor, but these receptors are widely distributed. and that's why the corticosteroids are having the endocrine effect. Corticosteroids are having effect on the various metabolism, carbohydrate, protein, fat. Corticosteroids are having effect on the calcium, effect on the skeletal muscle, effects on the immune system, anti-inflammatory action, and many more actions. This is not because the corticosteroids are acting on the multiple receptors. Corticosteroids are acting on the particular corticosteroids receptor, but these receptors are having wider distribution. While the another example is, there may be a drug which is acting on the multiple receptor. Okay, there can be a drug which is acting on the histamine H1 receptor, there can be a drug which is acting on the dopaminergic receptor, there can be a drug which is acting on the muscarinic receptor, and there can be a drug which is acting on all these 3 or 4 receptors, like in case of antipsychotic drugs, traditional antipsychotic drugs, that is chlorpromazine. The drug is acting on these multiple receptors, and that's why it produces the multiple effects. Okay, and obviously in the clinical scenario, it is the drug that is having a specific action that is always preferred. Okay, so in this class we have discussed about what is dose response relationship, what is its clinical importance, what is log dose response, what are its advantage over dose response relationship, concept of efficacy and potency, why the relative potency is more helpful in clinical scenario, then the nature of the curve, steep dose response curve and flat dose response curve, and very important, the therapeutic range. There is another definition, that is therapeutic index. Okay, that we will see in the next class, but for the practice, this therapeutic range is more important. And finally we see the drug specificity. Okay, now the assignment for the today's class is, what is the shape of dose response curve and log dose response curve, and are the same? Justify your answer. Then what are the advantages of log dose response curve over dose response curve? For the selection of the drug, which parameter is preferred? And for the selection, this is the mistake, for the selection of the dosage of the drug, which parameter is preferred? And yes, here you have to compare the efficacy and potency of drug P, drug Q, drug R and drug S. Okay, so you have to compare the efficacy and potency of drug P, Q, R, S. Then the next question is, how can you judge the nature of antagonism with the nature of log dose response curve? And you have to explain by giving example. Then what is the clinical importance of knowing therapeutic index of the drug, and name 2 drugs having a very low therapeutic index and 2 drugs which are having higher therapeutic index. Then the last question is, which care should be taken while prescribing a drug having steep dose response curve? So now the topics to be discussed in the next class is, obviously we will discuss in short about the therapeutic index, then combined effect of the drugs, because in the clinical practice, if you can see the prescription, in the majority of the prescription there are 2, 3 or even 4 drugs are prescribed. It is hardly you will find a prescription in which a single drug is prescribed. So what will happen? What are the pharmacodynamic consequences if you are giving the drug in the combination? You have to give the examples as well as the clinical significance of drug synergism and the different types of antagonism, physical, chemical and physiological antagonism. And last but very important antagonism, because you know that majority of the drug acts through the receptor, so you will find the agonistic drugs at the same time antagonistic drugs. Okay, so receptor mediated antagonism, this we will discuss in detail. What are the types of receptor mediated antagonism, what are its characteristics, examples and clinical importance. Okay, so wait for my next class, and if you find this presentation really useful in your learning of the pharmacology, then please share with your colleagues too. And also subscribe my channel, that is Pharmacology in Simplified Way by Dr. Darshan Dave. Keep sharing and keep learning. Thanks a lot.